Published today is a systematic review and meta-analysis on the efficacy and safety of vaginal progesterone to prevent recurrent preterm birth and adverse perinatal outcomes in asymptomatic women with a singleton gestation and a history of spontaneous preterm birth. Preterm birth complications are the leading cause of death among children younger than 5 years worldwide, accounting for 18% of all deaths. A history of spontaneous preterm birth is a major risk factor for recurrent preterm birth. Overall, the rate of recurrent spontaneous preterm birth is about 30%. Recently, some professional organizations have recommended the administration of vaginal progesterone to women with a singleton gestation and a history of spontaneous preterm birth, aiming to prevent preterm birth despite evidence about its efficacy, which remains unclear. Therefore, we conducted a systematic review and meta-analysis aiming to assess whether vaginal progesterone decreases recurrent preterm birth and adverse perinatal outcomes in women with a singleton gestation and a history of spontaneous preterm birth. We included randomized controlled trials that compared vaginal progesterone to placebo no treatment in asymptomatic women with a singleton gestation and a history of spontaneous preterm birth. The primary outcomes were preterm birth less than 37 and less than 34 weeks of gestation. The systematic review was performed according to the methods recommended in the 2021 edition of the Cochrane Handbook for Systematic Reviews of Interventions. 10 studies, including a total of 2,958 women, met the inclusion criteria, of which 7 had a sample size less than 150, small studies, and 3 had a sample size greater than 600, large studies. 4 small trials compared vaginal progesterone versus placebo, and 3 compared vaginal progesterone versus no treatment. All small studies were conducted in single centers located in low-middle-income countries. Only 2 small trials were registered, both retrospectively. The remaining 5 small trials were not registered in a clinical trials registry. All large studies were double-blind, placebo-controlled, registered, multi-center trials. 2 large trials were conducted in high-income countries, and the remaining 1 was conducted in both high-income and low-middle-income countries. This figure shows the risk of bias in each included study. Among the 7 small studies, 4 had an overall high risk of bias, 2 had some concerns of bias, and only 1 had an overall low risk of bias. The 3 large studies were at overall low risk of bias. A meta-analysis including data from all 10 trials showed that vaginal progesterone was associated with a significant decrease in the risk of preterm birth less than 37 weeks of gestation. However, there was substantial between-trial heterogeneity, and the 95% prediction interval contained values greater than or equal to 1, which indicates that vaginal progesterone could have no effect or even an effect in the opposite direction in some patient populations or in a new study. In addition, the treatment effect estimate in fixed effect meta-analysis was noticeably smaller than that in random effects meta-analysis, which strongly suggests small study effects. A meta-analysis including data from 9 trials also showed that vaginal progesterone significantly reduced the risk of preterm birth less than 34 weeks of gestation. Nevertheless, as in the meta-analysis of preterm birth less than 37 weeks of gestation, in this meta-analysis there was also substantial heterogeneity, a 95% prediction interval containing values greater than or equal to 1, and a smaller treatment effect estimate in fixed effect meta-analysis. The frequencies of other pregnancy and maternal outcomes did not significantly differ between the vaginal progesterone and placebo no treatment groups. Infants whose mothers received vaginal progesterone had a significantly lower risk of admission to the neonatal intensive care unit. However, as in the meta-analyses of preterm birth less than 37 and less than 34 weeks of gestation, in this meta-analysis there was also substantial heterogeneity, a 95% prediction interval containing values greater than or equal to 1, and a smaller treatment effect estimate in fixed effect meta-analysis. There was no evidence for a beneficial effect of vaginal progesterone on the other adverse perinatal outcomes evaluated. A pre-specified subgroup analysis according to sample size showed that vaginal progesterone was associated with a large decrease in the risk of preterm birth less than 37 weeks of gestation in small studies, whereas in large studies it had no effect. Importantly, the interaction p-value of less than 0.00001 for subgroup differences indicated that the effect of vaginal progesterone significantly differed between small and large studies. A similar subgroup analysis showed that vaginal progesterone significantly reduced the risk of preterm birth less than 34 weeks of gestation in small studies, whereas in large studies it had no effect. Other subgroup analyses showed that vaginal progesterone significantly decreased the risk of preterm birth less than 37 and less than 34 weeks of gestation in studies conducted in low-middle-income countries, single-center studies, and unregistered studies, whereas its administration had no effect in studies conducted in high-income countries and both low-middle-income and high-income countries, multi-center trials, and registered studies. Small study effects, defined as the tendency of small trials to report larger benefits of treatment than large trials do, were confirmed after visual inspection of the funnel plot for the outcome of preterm birth less than 37 weeks of gestation, showing pronounced asymmetry, which was statistically significant according to the Eggers and Harbert's tests. The contour-enhanced funnel plot indicated that missing studies would be the right-hand side of the plot in areas of high statistical significance, which suggests that publication bias is a less likely cause of the funnel asymmetry. Small study effects were also detected by visual and statistically significant funnel plot asymmetry for the outcome of preterm birth less than 34 weeks of gestation. A sensitivity analysis restricted to the 4 trials at overall low risk of bias showed that vaginal progesterone did not reduce the risk of preterm birth less than 37 and less than 34 weeks of gestation and admission to the neonatal intensive care unit. The adjustment for small study effects resulted in a markedly reduced and non-significant effect of vaginal progesterone on preterm birth less than 37 and less than 34 weeks of gestation. The quality of evidence according to the grade approach was judged to be very low for the primary outcomes of preterm birth less than 37 and less than 34 weeks of gestation, which means that the true effect is probably markedly different from the estimated effect. Evidence for the remaining outcomes was considered either as low or as very low quality for 18 outcomes, moderate quality for 6, and high quality for 2. The overall quality of evidence was considered to be very low. Although meta-analyses that included data from all trials showed that vaginal progesterone significantly reduced the risk of preterm birth less than 37 and less than 34 weeks of gestation, the evidence was highly conflicting because this intervention was associated with a large decrease in the risk of both outcomes in small studies, whereas in large studies it had no effect. There was clear evidence of substantial small study effects in the meta-analyses of the primary outcomes preterm birth less than 37 and less than 34 weeks of gestation. Small study effects can often distort results of meta-analyses. The main causes of small study effects included publication bias, true clinical heterogeneity, and low-quality studies reporting inflated effect sizes. Publication bias and clinical heterogeneity did not appear to explain small study effects in our meta-analysis. The most plausible explanation for small study effects in our meta-analysis is the poor methodological quality of most small trials, leading to spuriously inflated effects in these studies. In our systematic review, 6 of 7 small trials were judged to be at overall high risk of bias and some concerns of bias. In the presence of substantial small study effects, the Cochrane Handbook for Systematic Reviews of Interventions recommends restricting the primary analysis to studies judged to be at overall low risk of bias, or considering reporting the results of meta-analyses restricted to the larger, more rigorous studies. As previously shown, the meta-analyses restricted to high-quality large trials indicated that vaginal progesterone did not reduce the risk of preterm birth less than 37 and less than 34 weeks of gestation and admission to the neonatal intensive care unit. After examining the conflicting results between small and large trials on the efficacy of vaginal progesterone to prevent recurrent preterm birth in women with a singleton gestation and a history of spontaneous preterm birth, we concluded that there is no convincing evidence supporting its use in these patients.